Yeah, if you go ahead, if you wanna start, Dr.
I just want to be
Mike.
courteous to our guests who stopped in with us and spent their valuable time, right? Yeah, my name is Mike Boehmer. I appreciate you listening. What we're talking about tonight is a little bit deeper dive into what is methylene blue and how is it used and some of its mechanisms of action and how it, including some of the phototherapies. And then towards the end of the presentation, Dr. Halasa is going to kind of tie it all together for us. Anyway, start with our first slide. Just interesting to look at methylene blue, what it is. If you notice, it's a symmetrical molecule, and it has a nitrogen and a sulfur component, as well as two reactive components on either end. So it's a highly reactive molecule. And believe it or not, the electron transfers that we're going to talk about occur from this nitrogen here, actually. So this is where the oxidation and reduction occurs, and then this ring here changes configurations to accept or lose electrons, however the case may be. And this is what makes it a redox buffer. But anyway, that's kind of what the molecule looks like. But where did it come from and why haven't we talked about it before? I've been a pharmacist for 34 years and recently, only about 2 years ago, heard of methylene blue or is any kind of a therapeutic thing. The closest thing I knew of was gentian violet, which is, I guess, maybe a cousin or something. The molecule is actually related to chloroquine and hydroxychloroquine, which is interesting. And but because of its blue color, you know, it's been used for dyes and like this back in deep into history, I guess, or after, you know, into the 1800s when it was discovered. It's not a naturally occurring molecule, by the way. It is synthetic, but it was, you know, created, I guess, in the 1850s or 60s. Interestingly, probably around the time of denim, right? But anyway, it's been FDA approved as a drug after many, many centuries of use as a folk medicine and things of this nature. And we've actually had guests on our panel, the Nitro Medicine panel that you're on now, who have been from other countries where they've used methylene blue in their clinical practices historically. In India and Pakistan, I've heard of this being done, and they used it for all kinds of different things. But today, it's FDA-approved drug for methemoglobinemia, which is a redox-mediated pathology. And then, of course, it's been used extensively in laboratories as an indicator because biological tissues take up methylene blue. It's highly water-soluble and has a positive charge. It passes through membranes very well. It's pretty equally hydrophilic and lipophilic. So it, because of its odd symmetrical structure, I think just seems to pass through things easily. It's been used like in lymphatic imaging, things of this nature. But we're looking today at things like early Alzheimer's, Huntington's disease, Parkinson's disease, chronic neurodegenerative diseases. But it can also be used for a lot of other things. PubMed has, I think, over 60,000 studies, believe it or not, on it, peer-reviewed literature. Methemoglobinemia, septic shock, intrinsic microbial, antimicrobial effects. We have presentations on neuroprotection and neurodegeneration, which Dr. Halasa has a very interesting presentation on. Cognitive enhancement, possibly depression, skin aging as a antioxidant or redox buffer in the aging process. Photosensitizer, which is very interesting, and of course it's a redox buffer. So these are all things you'll find in these 60,000 studies and much, much more. Now, what are some general actions when we talk about actually giving methylene blue to a patient, right? It is a dose-dependent monoamine oxidase inhibitor. At lower dosages, it is a monoamine oxidase A, and then it shifts to A and B at higher levels. And typically, we aren't recommending high levels or anything like that. Thus, you would want to consider this in prescribing to patients with who are on, for instance, SSRI, antidepressants, or anything that would be metabolized via the monoamine oxidase process. It does inhibit nitric oxide synthase to some degree through the guanylate synthase inhibition process. It mildly inhibits cholinesterase, although I found very little in the literature to explain what that is. It does increase mitochondrial function, which is one of its primary areas of interest. It is a photosensitizer. Red 660 is absorbed and interacts with it as a photosensitizer. It will give a mild increase in blood pressure, which is dose dependent. It's not extensive or radical increase, but a few points. And then it has nootropic effects that are being studied as well as a cognitive enhancer. So this is a little bit more of a summary, really kind of a different slide depicting the same things and adding a couple more items. It does cross the blood-brain barrier. That's important to know. And then here's some just, it's highly absorbed orally. So oral absorption is very good. That's a nice thing to know too. We're going to talk about the improvement of cellular metabolism kind of across the board. But before we go to that subject, I'm going to kind of have a brief discussion of what we call nitro medicine. As you might imagine, the pH in the body is kind of the measure of the free protons that are circulating in the fluid compartment. And so and just as pH, we would say that it underlies all of the biochemical reactions that are occurring throughout the body on a global basis. And that's been given great attention, and we know that there are illnesses and problems and clinical pathologies that result from a gross alteration of the pH, or even really quite a slight alteration of the pH, right? So we know if there's too many protons, but we're looking so much at the or electron potential. Now, there's two kinds of basic chemical interactions that we have in our body, or two very basic ones, which are acid-base reactions, which are pH controlled, and then there's electrochemical reactions or redox reactions, and those are kind of governed by this ORP. So these are two of the major types of I guess, contributors to the underlying fluid compartment electrochemistry. And as we come to find, our genome has developed throughout time in the presence of oxygen. And that's, I guess, the theory behind why so many of these types of reactions exist. But it regulates many of our DNA-mediated processes, as the literature shows, and that it's quite possible to interact with these processes by manipulating the redox imbalances that kind of underlie them. So that's, in a nutshell, what we call nitro medicine. And here's a little bit more on that. This slide looks like it didn't translate from my PC to my Mac very well. But oxidation and reduction, right? And what you'll find out is that by using methylene blue, what we're doing is we are manipulating oxidative reductive balance in the fluid compartment of the body, and then this has clinical implications. So I just wanted to give a brief Chemistry 101 overview of reduction and oxidation in the presentation, just for reference, because it is somewhat confusing. Because you're gaining a negative or gaining a positive. So something can have a negative charge but gain a positive, and it gets a little bit confusing to think of. But if you look at it this way, it's really the gaining or loss of a hydrogen, or the gaining or loss of electrons. And that happens kind of opposite each other in a yin and yang thing that is balanced. There's no third option, so to speak. It's just an equilibrium. And so this equilibrium then controls a lot of different things, right? Redox imbalances underlie epigenetic expression and cellular processes that are the root cause of many chronic diseases. And this is a fundamental belief or kind of a principle of what we call nitro medicine. And it comes from the oxidative stress related theory of aging itself and the interaction of our genome and development in this manner. So as we talked about, pH is the control of acid-base chemistry, and this is very tightly controlled by the body. Pathology exists if it's not controlled. redox potential kind of controls the electrochemical environment at the molecular level, thus impacting fundamental biochemical process throughout the body. But it can also be not really controlled so much by literature has shown that why can't we just give lots of antioxidants to people and control this? And that doesn't work because of internal reactive oxygen species production and toxins and other variables, including the compartmentalization of different tissues and things. You really can't give somebody enough vitamin C, so to speak, to correct a global redox imbalance, although it can help, right? So we talk a little bit more looking into this deeper. We have oxidative stress and we have kind of oxidative stress, right? So it's important that the redox controlled signaling has some level of stress on it. Cells need to function properly, and in their normal function, they do produce reactive oxygen species and what we are calling oxidants nowadays. I think the literature is tending away from the word ROS and now just defining them as general oxidants. But we used to, if you live long enough, the names of things change, I guess, right? Anyway, there's a eustress and an oxidative stress level. So if we have too much oxidant level in the body for whatever reason, this promotes macular molecular damage and mitochondria dysfunction. There are dysfunctions in the cellular membranes. The kinase phosphatase processes don't function as correctly as they should. You have, and essentially disease processes are stimulated. But likewise, with amount of stress, balanced system, we have health and longevity because we are, utilizing these processes in a balanced way, kind of leading to homeostasis. Let's see. So here I talk about not using ROS. It's already been in the thing here. So this is a little bit more of a summary here. It's a bit redundant, I guess, but reactive oxygen species, or oxidants, are necessary for normal biochemical function, but they induce pathology when imbalanced. So our endogenous production is essential to tissue and cellular regeneration and healing. And a lot of our initial thoughts on this came from the stem cell research folks and people who were trying to understand why and how stem cells could be have a better success rate in some people than others, and what was explaining these processes. So excessive ROS production and subsequent accumulation leads to detrimental processes of inflammation, and you could look at this in a way as the root cause of aging. So oxidative stress-related disease caused when our antioxidant defenses, which can be small molecule and endogenous enzymatic things and all of that they're overwhelmed by ROS production or exposure. And then this triggers epigenetic pathways. And then within these epigenetic pathways, there are the kind of faulty instructions that lead to chronic disease states. And then, the other thing is that many people, I think, will find the subject interesting if you are a seeker of the root cause of diseases and what is the root cause of, the actual pathology. So what does redox potential really control? And the answer is cellular proliferation, differentiation, and apoptosis. So in the proper electrochemical environment, or the favorable electrochemical environment, a cell will do these different things. It's sort of part of this balance that decides whether the cell is in a state of flux between, life, coding for life and death, so to speak. And I guess this is really kind of inflammation that controls the inflammatory processes. Now we can control these things with photodynamic therapy, with photomedicine, and with redox buffering substances that are safe to administer. One being methylene blue, but there are probably others. So this is a fascinating slide if you really kind of take in what it's saying. As the cell indicates towards oxidation, we go towards this. So oxidative stress leads to premature apoptosis, right? Whereas if we manage things in the middle, we get differentiation and proliferation. So how do we do this with methylene blue, right? What is methylene blue and what is it doing? And I thought this was a nice slide I found, and I'm not sure who to credit for this. I can't say that that was my work. But it shows how methylene blue, when it bounces back and forth, note that we mentioned here on the molecule in symmetrical form, where this nitrogen molecule is, that this particular ring with the sulfur and the nitrogen can accept or lose electrons. So in its reduced form, it has taken a proton, it loses a proton, therefore it is oxidized. And it now is, I guess, able to, so this bounces back and forth in a yin and a yang sort of a way, right, in an equilibrium. So that's kind of, I don't know if that's old news or not, but so what are the clinically significant mechanisms of action then in the areas of primary clinical interest? And methemoglobinemia is one that is the root of the FDA approval for the product. So I thought I'd briefly discuss that. Then mitochondrial dysfunction, and then phototherapy. So we'll just proceed through those topics real quickly here. And then I've included a couple of key study references on each of these that give a good general, more in-depth view of what is involved there. So in methemoglobinemia, where are we going here? Okay. With methemoglobinemia, essentially it's an oxidative stress related disease where the electrochemical balance between the blood is damaging the hemoglobin's ability to carry oxygen. And this is the mechanism of action there, where the GCD enzyme is involved in the conversion of this of NADP to NADPH through NADPH reductase. So when we talk about methylene blue later, we're going to discuss that, that one contraindication is that there are patients who have this G6PD enzyme dysfunction, and those patients should not be given methylene blue. So that's one thing to know. But anyway, this is the mechanism of action for the FDA-approved product for the methemoglobinemia. Essentially, what's happening is in the bloodstream, the ferrous iron is oxidized by the predominance of reactive oxygen species in the circulation. This oxidizes the ferrous moiety to a ferric moiety, which impairs the ability of the heme to transport and deliver oxygen. So methemoglobinemia is really a disease that's, I don't know, fairly rare, I guess, and it was approved because it's a tragic condition and it's due to toxicity and things of this nature. So it requires acute care, and that's kind of where the FDA-approved product came from. So you need a lot of methylene blue to counteract this, and one area to know about prescribing a methylene blue is that the FDA-approved product is a very high dosage for very critical acute illness, not something that's designed for longer-term use. So as we talk about longer-term use, we're looking at much, much lower dosages. So you wouldn't want to be confused, by reading the literature about one purpose, then constraining that to another use. So when we talk about, we talked briefly about methemoglobinemia, and then now moving to mitochondrial dysfunction, which is, I think, the more interesting area for most folks. What do we have on hand to control, or what are the medications or things that we know that work to control mitochondrial function or improve it? And what was on the list in that area I found was CoQ10, methylene blue, idebenone, curcumin. This item here I do not know anything about. These is just omega-3s. Then we have mitochondrial targeted peptides, creatine, the CBD and triterpenoids, and ginkgo biloba. So these are all things that I think naturopaths and people are using in mitochondrial therapies in literature. And so we're going to focus in on methylene blue, and then we'll probably talk actually a little bit about CoQ10 and the interaction that's interesting there. So in further study, we could discuss more about these other items if of interest. And here's some things, what happens when our mitochondria dysfunction, and this is why the this is an oxidative stress-related disease is of interest to many different people. But if you look at the wide range of medical specialties this covers, from neurology to immunology to, I guess, pharmacy here, right? Medication-induced problems, infectious disease, toxic or metal toxicity, and cancer-causing carcinogen toxicity, genetic mitochondrial diseases. There's cancer, chronic fatigue. So many, many medical specialties are involved in diseases with mitochondrial function. So what does methylene blue do when a patient is treated with it? Number one, it acts in the mitochondria on the electron transport system, the complex 1 through 4. And then when this complex is malfunctioning, you have a gross decrease in ATP production. So the patient is functioning with the powerhouse operating at half speed, so to speak. So methylene blue can work to correct that problem. An electron donor, actually, and we're going to go through this more in detail, but we're going to work through Cytochrome C to donate electrons to cytochrome oxidase process, which increases oxygen consumption. We're going to increase the amount of NAD, and then we're also going to directly neutralize free radicals that are generated within the mitochondria. So that could be from really any form of defect. And then so that's really reducing the effect of mitochondrial inhibitors by scavenging electrons and neutralizing of free radicals in the cytoplasm of the mitochondria. And then in high doses, we can even go further with it and use it deliberately in high doses to deprive electrons of active oxygen species. And this is how the antimicrobial effects work. So we'll talk a little bit more about those things as well. Let's see. So this is really just kind of another visual reminder of what we just talked about. So, okay, now moving to the actual mitochondria, this is a broader view, okay, and we see here the outer membrane. Let's see if I hope you can see my mouse cursor. This is the outer membrane of the mitochondria and the inner membrane. And here we have the enzyme processes that are the electron transport system. And so you can see how this operates, the citric acid cycle, and this is how it's operating. Now, what does methylene blue do here? Okay, when we get into this, methylene blue, as you can see, it can be oxidized and reduced at this moiety. And when it does this, it is changing from methylene blue to leucomethylene blue. This is the neutralization of a free radical here when that happens. In addition to that, electrons are transported and given to cytochrome C. Now, cytochrome C is a critical, actually very interesting protein that is evolutionarily conserved throughout many, many different species. And it's a heme itself. And is part of our oldest evolutionary biology, and it's involved in electron transport and energy production, and also cellular apoptosis. So when this little guy doesn't function well, that's a bad thing. And it must exchange these electrons in order to function. CoQ10, believe it or not, also provides this service to cytochrome C, just as does methylene blue. So they are actually competitive inhibitors of each other. I don't know that that matters or what the sum total of it is, but if a person is taking methylene blue, it may be less necessary for them to have CoQ10, which is kind of interesting. And Dr. Halasa, did you have further comments on any of this part?
Oh, no, I'm good. I'm good. I think, yeah, they say methylene blue does interfere with QQ10, so we don't know. They have the same side of action.
Right.
So what's that mean? If you give QQ10 and give methylene blue, they compete on the same side. That's it. But does not mean that they are kind of decreasing the effect of others.
Right, that's my
That's a good one.
understanding as well. So that's been a common question is, you can see that they're they each are contributing an electron that ended up in Cytochrome C, but they do it in a different place. So, which is right here, and it ends up over here. So but essentially we're talking about a grave reduction in the production of ATP if in a damaged mitochondria. It still functions, but it still functions about 25% level of production of ATP. So now what is the result of this is if it malfunctions, we end up with reactive oxygen species being produced, and that leads to pro-inflammatory cytokines. And then in this case, we're looking at neurodegeneration. So if the electron transport system singlet oxygen, if the electron transport system is disrupted, singlet oxygen ends up produced inside the mitochondria. And this is what signals for pro-inflammatory cytokines. This is the beginning of that pathway. So if you can stop that here by using methylene blue, then you may predictably limit these other downstream effects. So you're intervening right at the place where it happens. And of course, that pathological reactive oxygen species can cause also, if they build up enough, they can cause apoptosis. And that in its own self, apoptosis causes cytokines and all kinds of subclinical inflammation and things of that nature as well. So let's say we correct all that, and we do it, and we have our methylene blue and our leucomethylene blue. We can neutralize the free radicals upon production, thus reducing the chances of cellular apoptosis or further downstream release of pro-inflammatory cytokines and the stimulation of PPAR and NF-kappa B and all those other things. That happens downstream of this. So, and then it's also interesting to notice that the actual effective drug here, right, because it's actually made to methylene blue and then to the leucomethylene blue, which is actually what donates the electron. So anyway, I guess that's just a fanciful note if you find that interesting. That was a lot to talk about, but we're going to, I guess, proceed to photodynamic mechanisms here. Okay, and Dr. Halasa, would you like to summarize really where we are at this moment so that we are all up to the same point?
You mean right now you want to talk about photodynamic therapy? Is that what you're summarizing?
Well, yeah, I just wanted to say, do we need to focus any more on mitochondrial function?
No, you did good. Just proceed with what you have. I think you have very excellent material that actually summarize all the work that we are doing. So I'd like you to continue because this gives the audience the basis of understanding that the chronic diseases pathophysiology is due to imbalance in redox status and due to imbalance in the redox epigenetics, which can affect the cytokine storm, it can affect the cell cycle, it can affect many physiological processes of our bodies. So normalizing the redox sensitive epigenetics and biochemical pathways is the approach that we are trying to come up with. It's all our protocols based on that. Again, versus the big pharma, which is creating molecules that will modulate the chemistry and the physiology of the body using the concept of key lock concept. And so I need the doctors to understand the difference between key lock concept and nitroredox modulators. Once they understand that, then they can understand how the integrative medicine works and regenerative medicine works, how stem cells works, how PRP works, how photomedicine works, what's the mechanism of action, so we can translate it into the mainstream medicine. And so you're giving them the chemistry that they need. As a pharmacist, I think this is what, as a pharmacist, this is your duty or your job or your perspective as a pharmacist to provide all this chemistry that the doctor needs so they can really validate all those therapies that we're doing, and we can easily get the mainstream doctors on the board, and that's our main thing to do. So go ahead. I think you're doing good. Just continue what you're doing.
Okay. One other point I'll make to add to what you just said is that even with the pharmaceutical drugs, no matter what you would use, if you address the problems that are in the underlying fabric of biochemical platforms, you know what I mean, the redox imbalance, the electrochemical system, you know, you're helping all of it at the same time, right? So it can go on its own or with you know, any other
Let me add another thing. You know, we saw the big pharma products do have very good effect in acute conditions, but when you use those big pharma products in long term, it does interfere with the redox balance. It does interfere with the mitochondrial, and that leads to the side effects. All the side effects of the big pharma products mostly is due to modulation, you know, in a bad way, the redox balance. And that's why patients would end up with tolerance, would end up with all the side effects. And so the big pharma, when they produce those products, they are not tested against the mitochondrial function. And so that's the problem that we have with big pharma. Like statin, for example, it can interfere with mitochondrial function, and it can lead to oxidative stress in long-term use. Yes, in the beginning, it helps to buffer the redox. It is sort of nitric oxide donor indirectly, and it helps the endothelial function. But with long-term, it can interfere with the mitochondria, so you need more of statins in order to balance the side effects. And that's why they give QQ10 to balance the side effect of statins. So this is just going to give you an example of how big pharma products, their effects is good in the short term, but in long term, most of the time, they end up with side effects, and side effects emerge due to modulation of the nitric redox in a bad way.
Right.
So that's things I want to emphasize on.
So by modulating this ourselves, we can improve the side effect profiles potentially. You know, that's all. These are all things that we have interest in looking into. So, but yeah, one of the fascinating things about methylene blue, if you ever see it, and it is how blue it is. It is, our laboratory hates methylene blue more than any other chemical. They'd rather do, you know, a cytotoxic methylene because it makes such a mess. The tiny speck of it will turn gallons of water blue. It is very, very blue. So it's very interesting to see. It almost looks black. And I would encourage you to get some and kind of look at it. It's interesting, but you'll see immediately why it's a photosensitizer, right? So what does a photosensitizer do? And well, there is basically it's fluorescence or harmonic resonance, I guess you could call it, and light energy just simply strikes or interacts with the methylene blue. And because, again, remember, it is, if you look at it, it's symmetrical. It's exactly symmetrical, but it's electrically imbalanced. And I think it vibrates literally in some form. And that kind of changes that tricyclic structure, and it allows it to become very excited, and it absorbs energy, and it goes into a state of, it's called a singlet state. And in that state, it's incredibly reactive, and it immediately reacts with kind of anything around it. That's like a super bad, you know, gamma ray-like thing. But naturally, it just simply loses energy and dissipates to a triplet state. So if it is excited into a singlet state, it doesn't immediately react with something, which it can do. It will pretty quickly, like within microseconds, relax to this triplet state. And that is where there's two types of reactions that can happen. And they call this Jablonski's diagram, okay? And this is like, I guess, a classic explanation of how a photosensitizer excited to a singlet state donates electrons to oxygen. And that makes it superoxide. And of course, superoxide is the worst type of free radical, and it triggers all kinds of epigenetic pathways and inflammatory responses. And of course, it just simply wants to attack other molecules to get more electrons. Now, healthy versus, and then, okay, so then the other one here is tissue-based, okay? So if you interact with superoxide, it's gonna, you know, covalently bond to things. It's gonna do bad things to tissues. But when you have this tissue-based reaction, what you do is you're simply producing free radicals of a different sort, and they're the less pathological free radicals, but these are also inflammatory signalers. And the reason we're doing this is in photodynamic therapy, our goal is to create to move the redox balance in the direction of oxidation. So through this process, you can do that. So it's a tool, a clinical tool that you can use to push things in the oxidation direction. And if I refer back to this slide really quickly, this is the implication of that, right? So we're moving things to the oxidation side, and that's why we can use it for photodynamic therapy. We can push it into this minus 150 millivolt range that triggers for apoptosis and that genetic process. So that's what photodynamic therapy is, and that's how it's used to treat cancers and other really kill other cells, right? Whether they're pathogens or not. And interestingly, healthy cells are fairly immune to this process because they have the ability to buffer their own redox when they're healthy. So, under a very high oxidative stress cell, you end up with reduction, okay? And I got the slides backwards. Never mind. Here you go. In healthy tissue, okay, we just get a slight movement towards redox, and that's like a eustressor. Okay, I guess you could call it that. So if you're using your infrared light in a patient that's healthy, it's more of a eustress of shift slightly towards oxidation because the normal cells in the patient's body are buffering the redox. In a cell that is like a cancer cell or something, a whole entire different process takes place. And that's because the cell already has high oxidative stress. So I'll let Dr. Halasa explain this, and this is the one that I wanted you to explain to me.
Yeah, but this is for patient with inflamed, if you have inflammation or you have hypoxia, and you add the light, the infrared light. So these photons will help to excite those electrons. And who's going to be the electron acceptor here is going to be the NAD, not the oxygen, because you do have too much of NAD already because of the depleted energy of the inflamed and hypoxic tissues. And also you don't have too much of oxygen at that time. You will have, in this condition, you have too much of NAD. And so those NAD, they will pick up those electrons, they become NADH, and this is called reverse electron transport chain. And you turn into NADH, and NADH will reduce the glutathione, and that will end up, scavenging those free radicals. And so when you're scavenging the free radicals and you decrease the free radicals, you decrease the inflammation, right? So this is the opposite effect that happened to the healthy tissue. In healthy tissue, you have too much of oxygen. You have energy in the form of NADH, so you don't have to. So what will be the electron acceptor here is not NAD, it will be the oxygen. And then you'll be shifting the redox into oxidation. So the light effect on hypoxic and inflamed tissue is shifting the redox into reduction and decreasing the inflammation. The light effect on the healthy tissue is actually exciting those electrons, will be picked up by oxygen and shifting the redox into oxidation, into physiological oxidation that will help to stimulate the stem cells and the gene expression of the proteins. So it's a good thing, right? So this is Redox Biomodulation. That's another name that I'm putting in instead of photobiomodulation, but exactly what they biomodulate. They biomodulate the redox. And the light does help to buffer the redox. In terms, if it's low, it brings it up to the physiological level. And if it's high and pathologically, it brings it down to physiological level. So it helps to provide that homeostasis in the redox status, or buffering the redox. That's the best thing I like to label so we can understand the mechanism of infrared and light therapy on healthy tissue versus the normal tissue. And you can do it in animation. So I don't know why you don't put the slides in the form of animation, so you can see the whole animation process.
I didn't know that. See, that's why this is our first time to do these two slides. So
so all those is animated slide. Those two slides are animated slides, so you can see the whole steps of the process of shifting the redox into reduction and oxidation.
Okay,
So,
I'll have to learn more on that then. This is our first
so
presentation.
you click on animation process. Do you see that? There's a box where you click it up.
Yeah.
Just click on that. Turn into animation the whole program. Do you know where to click?
Yeah, I think it doesn't seem to do it.
It's on the top. Do you not have that? You cannot
Oh,
turn into
play.
animation. No, up. Yeah, here we go. Well, is this animation?
It's supposed to be.
Yeah, see
There
here.
it is.
Yeah.
Oh, cool. All right.
Okay. Same thing for the next slide too. And so the electron acceptor is different from inflamed tissue, hypoxic versus healthy tissue. The electron acceptor is NAD in the inflamed and hypoxic tissue, and it is oxygen in the healthy tissue. All right. Good. And I think you showed that the healthy one. Okay, let's go with the next slide. Photodynamic therapy, right? Okay, this is easy one.
Did you want me to continue?
Yeah,
Okay.
yeah. Because
Yeah,
you're going to present tomorrow as well.
Yeah, right. Yeah, it's very, yeah, this is basically just simply a visual of it. So, you know, when you use photodynamic therapy, you're deliberately increasing cellular toxicity and apoptosis. And so when you're treating really I guess, what are they using this for? They're using it for Lyme disease. They're using this for, we've actually worked with potentially using this for COVID. We have worked with this potentially for use in different kinds of skin cancers, onychomycosis, which is a toenail fungus. So what you're basically doing is you're using methylene blue, attaching it to the tissues that you're looking to, or really the pathological tissues, and saturating with the methylene blue to the extent that you can, and then you're using the 660 red light. And that is this whole entire photodynamic process that we've been talking about, and it ends up in tumor destruction, you know, with just simple procedures. You end up just irradiating the tissue. And there needs to be a protocol with this, and we can discuss that more because the protocols are different, and we're, you know, kind of, that's one of the things we're working with. How long do you do this for? When do you do it? And more of the details. So I wanted to move kind of into the dosage and administration while we had a little bit of time. It's FDA approved for methemoglobinemia and intended for temporary use at 0.5 milligrams per kilogram, which is to 4 milligrams per kilogram, and that's very, very high. I have not seen anybody get dosages anywhere near that. 0.5 milligrams per kilogram seems to be about as much as anyone would take on a daily basis. Ongoing oral dosage should start much lower, 5 milligrams twice a day, 10 milligrams a day, and then up to 20 milligrams twice a day has been fine in most people. I've never really had anybody need to or want to go higher than that, but we've had no ill responses. We did have one patient I can tell you about that was sensitive and had to start slower. Another thing you can do is a little bit higher dose if you do a single or booster dose before PDT. We've seen people doing that. And still, again, they're far, far under these dosages. So they're safe and, you know, less than half of the FDA approved dosages. If you use intravenous methylene blue, which we do have available, you use a slow infusion over 15 to 30 minutes, but you don't push or bolus it because you get too high of a localized level. Because remember, it's a redox buffer, so you're pumping a redox buffer, and you got to go kind of slow and let it mix and come to equilibrium with the stuff you're with the blood. So you don't inject an IM or SQ, basically same thing. It creates a locally excessive dose, and it is not for use intrathecal or intraspinal. That was something that came up in the FDA research. They didn't recommend doing that. Let's see, it's very highly bioavailable during oral dosage. Your patient gets 95% of the dosage that you give orally. So that reduces the need for intravenous use because there's not, a massive attrition. The half-life is about 5.5 hours. Peak levels, you can look, I have some pharmacokinetic studies. It's somewhere between 30 minutes and 2 hours, depending on the patient's situation and how you administer. But if you do it typically just in a water-based solution or a capsule with a glass of water, 30 to 60 minutes seems about right. And then, of course, intravenously, the peak levels are like immediate. They're like, 2 minutes. IV dosage can provide higher levels in deeper tissues more rapidly, and it may be favorable for targeting the CNS. There's a study on that we have. Of course, daily dosage should, just as a caution, don't get confused. Look to the FDA-approved product and then note that the dosages there are for acute toxicity use, not for daily use. Let's see. And then contraindications: pregnancy, not pregnant. GFR should be over 30. We've kind of done some research on that and confirmed that that seems to be about right. Caution with Mao inhibitors. Again, I don't think a person on a tiny dose of Prozac will have a problem with 5 milligrams a day, but you need to be aware that people that are taking especially high doses of any of that type of neuroleptic or SSRI, SNRI, norepinephrine stimulator directly, those would all be things to look at.
Well, that's why Methylene Blue is being used as for antidepressant. So I met with a doctor, and he's actually giving high dose. I don't know, it's too much. He's giving up to 100 milligram, and I told him that's very high, because when the big pharma is trying to develop Methylene Blue to treat Alzheimer, they try the 10 milligram versus 100, and they say no difference. So they are recommending 10 milligram for Alzheimer diseases daily. I was a little bit discussing with this person who was treating the patient with depression using Methylene Blue, because it does help to increase the serotonin.
I would say that it's okay it's not harmful if it was under the care of a knowledgeable person, but the thing would be it's like anytime you give a serotonergic agent and a monoamine oxidase inhibitor deliberately, you want to be a psychiatrist.
Yeah, so that's what you need. You just need to make sure that you monitor the patient. So if you want to go with high dose, even for cancer, and we do high dose for cancer, you can go up to 1 milligram per kg for cancer patients, because you need to weigh the benefit versus the side effects. And now you're getting the benefit, but just monitor the patients at least bi-weekly, measuring their blood pressure and, getting their history and everything is okay, their mood is okay. And that would help. But then because patients can't tolerate that dose, but some does not. So you want to just make sure that you are on the same page here.
Out of several hundred patients, we have one report of a person that didn't react well to 5 milligrams and had some stomach discomfort and things of that nature. So I think it's actually quite rare. I've had really no other reports of that. Most people actually enjoy taking it because they do get a little bit of a mental lift, but it's not anything, major.
It does help to improve the mood, especially if you are on narcotics and
cognition. So a brain fog, like a patient with brain fog or something like that, that might be something to look at.
It improved the cognitive function according to the publications.
There are publications, yeah.
So that's a good thing about it. Gives you some sort of, more.
Yeah, you'll find Methylene Blue in some of those nootropic mixes. This is important. Remember, we talked about in the methemoglobinemia process, the G6PD enzyme is very important in that process. And if patients don't have that, they do not, the whole methemoglobinemia treatment process doesn't work for that patient. So a patient should not have G6PD deficiency and use Methylene Blue or intravenous vitamin C if you're doing that. There's another note, CoQ10 competes with it. So not harmful to use them both together, but they're doing the same thing. Just beware of that. Never give a full systemic dose by IM injection or SQ injection. I've been asked about intralesional injection, and based on these recommendations, I'm saying probably not the greatest idea unless it's something you're intending to.
No, intratumor is okay. We did it. It doesn't matter for intratumor.
You're going to remove it anyway.
Again, yeah, intratumor is okay. If you inject inside the tumor, you want to do photodynamic therapy, that's okay.
But I've had people ask about like injection into muscles and
No muscle. But if you want to do that, not muscles but tendons instead of steroids, you can do it, but very low dose. Don't go above 1 milligram, up 1 to 5 milligram. Don't go above that. If you want to do it, if you want to inject the joints, you can inject the joints. I mean, we are already doing it for joint injection methylene blue when we have any capsule damage of the joint and you want to know the leakage. By the big pharma, I mean, this is the mainstream medicine. They can recognize the leakage by injecting methylene blue in the joints, and they can see all the leakage, and they can go ahead and fix that. So the methylene blue is being injected into the joints. I think in ligaments you can, but you need to do low dose. There's no need to inject it into the muscles unless you have cancer there. But interstitial for cancer, yes, it's part of the protocol that we recommend. Again, it's better if to load it inside platelet nano medicine. That's better for, especially with cancer. I mean, they can attract cancer as free, but adding the platelet lysates and nanoing also will add more. It will increase the bioavailability, and it does help to get those drugs into the target in case you're doing IV methylene blue. So this is things we're going to discuss. We're going to talk about it next time for nano.
Yeah, those are subjects to come. So, I guess one other thing probably that's important to know is that if anybody does get more, like if you were to give somebody 5 milligrams, that's too much for them. The normal response is if somebody were to complain of nausea, dizziness, or sweating. Those are by far the first signs of any, and really, frankly, I've not heard but 1 or 2 reports of any of this kind of thing. And there's a lot of people taking 20 milligrams twice a day, 10 milligrams twice a day. So I still think these have to attend, doses that are safe. So it's not too much to worry.
So according to France,
one important thing.
Let me add something. In France, 2,500 patients with cancer, they are taking methylene blue as part of the treatment, could be photodynamic therapy. None of them had COVID-19. So, and then I have a doctor, his name is Dr. Bennett in California. He used it for 200 patients, around 200 patients, and none of them have COVID-19 cytokine storm. I'm not saying COVID-19 infection. What's very important in managing COVID-19 is not to stop the infection. Yes, slowing infection helps decrease the load of the hospitals, but really our target is to prevent descending into cytokine storm. So none of those patients descend into cytokine storm. We have Dr. Joseph also. He's been surrounded by doctors who are being infected with COVID-19, and none of them, they got sick, and he gave them methylene blue, and that helped them to prevent them from descending into cytokine storm. Dr. Joseph will maybe give some of his, summary of his protocols of COVID-19 with methylene blue with COVID-19. He's here.
That would be great. Well, this is my last slide. The only other important note I'll leave you with is that if you have a person on methylene blue, it may interfere with pulse oximetry to read artificially low, because it is, you've got, it's working with the hemoglobin to improve oxygenation. So it's actually doing some of the oxygenation's job. Another thing to know about methylene blue is you can buy it on the internet for like $1, but it is contaminated and used for industrial purposes. So be careful not to let patients buy methylene blue off of YouTube or eBay or wherever they're getting it, because they're getting industrial grade, not pharmaceutical grade product. Even the pharma grade stuff has to be specially tested. And so there's like lower grades, and they can literally contain the heavy metals that you're concerned your patients are toxified with: arsenic, aluminum, cadmium, mercury, lead, things of this nature. So no recommendation for methylene blue to be used, with the non-pharmacy grade. Important note there. And that is really all I have. Here's some study references. And of course, anybody who'd like to know more, we're happy to discuss whatever. So thank you very, very much.
Great job, Dr. Mike Beamer. Wonderful. A big clap for Dr. Mike Beamer for his presentation. Do you have any questions for Dr. Mike Beamer? He's the boss today.
You guys tell me.
Yeah, any questions? Dr. Joseph, do you have any questions?
No questions at the moment. As far as my experience with Methylene Blue, without giving a slideshow, if that's okay, I mean, if anybody's new to how Methylene Blue works with doing a mouth swish and then using the right light frequency, just basically a mouthpiece every day, I can go through the basics, because I think sometimes we think that everybody knows this stuff. It certainly is common sense to me, and it's common sense simply because I don't understand why somebody would not do this, considering you never really know how sick you're going to get with this virus. And even if you survive and you get through it, you don't go to the hospital, you get over it in 7 days or 10 days, you still can have a lot of sequela, in particularly the autonomic symptoms that people have for many months afterwards, simply because this virus is not just a vascular disease, it's also a neurological disease. And there appears to be ACE2 receptors in the autonomic nervous system, in particularly the parasympathetic nervous system. Of course, I did some research to find real data to support this, and there was lots of it out there. In fact, Big Pharma is looking to make specific drugs that enhance parasympathetic innervation, because that's really what's getting lost here. At least the symptoms that my colleagues have experienced are vagus nerve specific. And of course, considering that the vagus nerve does have a connection to the tongue, and that seems to be the primary route of infection, therefore some sort of dampening of the parasympathetic or the vagus nerve, or it actually spreading from the vagus nerve into the brainstem. They call it the bulbous region, where the vagus nerve enters before it goes back out along the cervical spine and into the heart and lung, and a connection to the diaphragm, which people who have the sequela, they are having tachycardia or intermittent bouts of heavy breathing, or a feeling of heaviness in the breathing, which is really paralysis of the diaphragm and it pushing up. That's the heaviness I believe that they feel. And then GI symptoms, nausea. My colleague also had bouts of nausea and dysphagia at the same time, a difficulty in swallowing. Fortunately, this was limited because I believe that we brought the viral load down quickly with the Methylene Blue. Back to what I was saying before, and I'll get back to that, is that there's also seems to be a connection between the vagus nerve and the spleen, GI tract, and the direct or indirect stimulation of the cytokine storm via its action on macrophages. And that's really where they were targeting drugs to block the fact that a dampened vagal tone in general causes downstream in the gut and spleen macrophages to release all of those cytokines or an excessive amount of cytokines.
Well, the
That's
other
really
thing
why-
that you need to mention when you damp the vagus, which is parasympathetic, you're allowing the sympathetic to be overactive and become dominant, and that leads to tachycardia. Is that what your friends was experienced, tachycardia?
Yeah, that's really what's happening. You know, the way I see it, when you're dampening the parasympathetic nervous system, what you're really doing at the same time is causing activation or overactivation of the sympathetic nervous system. That actually makes a lot of sense. And so therefore the symptoms such as tachycardia, dry mouth, one complaint where my colleagues were both complaining of severe dry mouth. And this is weeks after they had their full sequela, I would say about 7 days of infection, which was probably much, I would say, the actual disease course was shortened and was less severe because they did methylene swishes every 6 hours, along with doing the red light mouthpiece. You know, I still don't have a really good name for it. And doing that for about 20 to 30 minutes. I told them just do the full 30 minutes, you know, just around the clock. That's what got them through it with minimal sequela. Me, I was around them the whole time in close contact. We almost never wore masks around each other, no social distancing of any sort. And I believe I decreased the viral load so far that the only symptom I seemed to have was I had sort of like a neck tension. And that's it. And the only reason why I related it to COVID was simply because my colleagues also had the same issues, excessive neck pain, and of course they had full-blown headaches. And when I reviewed the literature, it became obvious that there's a strong connection between the vagus nerve after it leaves the brainstem going parallel with the cervical vertebra. And as an osteopathic physician, we know that there are a lot of that connection is very strong. That neck spasms and neck pain are intimately related to the levels of, you know, irritation and what the irritation is coming from. In this example, it's the vagus nerve. That's the neck spasm that I probably have been feeling, but that's it. And it's obvious. You know, I've been doing this Methylene Blue for 3 to 4 months. As soon as, literally at the beginning, I would say April, when I first kind of got connected to the whole area of oxidative stress. I mean, I thought I knew oxidative stress before now, but now understanding redox reactions and potentials, this is a language I realized that me and most other physicians that are still in our transition from regular medicine to anti-aging medicine, most of us don't really understand this. We know the words oxidative stress, but it doesn't have quite the meaning as it does once you really start to understand redox potentials and reactions in general. So
let me add something to what you have there, so that will give some more explanation of what you are doing. When you damp the vagus nerve, which is parasympathetic nerves, they are actually anti-inflammatory arms, because when you have active parasympathetic, it inhibits the sympathetic. Sympathetic is pro-inflammatory arm because sympathetics secrete norepinephrine. Norepinephrine stimulate the NOx enzyme that generate the free radicals and cause inflammation. So, you know, the psychosomatic diseases is part of it due to imbalance in the autonomic nervous system, where you have too much of sympathetics and release of norepinephrine in the tissues. And that leads to stimulation of NOx enzyme, generate free radicals, which will aggravate any local inflammations. So possibly your neck, it could be part of it. It is due to sympathetic overactivities. It can cause some inflammation and irritation and pain as well. And that was part of the mechanism of complex regional pain syndrome. But in general, psychosomatics works in that way. It works through sympathetic nerve, and they get overactive due to, in this case, you have the parasympathetic is being damped by the COVID-19. And then you can really cause all this aggravations of all those diseases, or it can lead to inflammation, can give you all this local pain that you experience yourself. So this is very important to use ANS as a diagnosis of the effect of the COVID-19 on the nervous system. And we can use endothelial function tests, because we know for the fact that patients who are at risk of COVID-19, there are the patients who are hypertension, diabetes, and obesity, and also male baldness can lead to increased expression of serine protease, which primes the COVID-19 virus. And so you have that risk yourself because you're bald, you have androgenic alopecia, and so you have those viruses being primed by serine proteases, and those patients are highly risk of descending into cytokine storm. So that's the reason why we think it's better if we start screening all the people with using endothelial function tests, and if they have poor endothelial function tests, we need to give them a complete package of integrative therapies to optimize their health and optimize endothelial function. Because if you have an endothelial function test, stressed endothelium means overexpression of ACE2 receptors. That's a fertile ground of COVID-19, and that leads to cytokine storm and all those organs, inflammation, multi-organ inflammation that we experienced in patients in ICU. So I think you are, with hands-on, you experience all those manifestations, and we're just trying to come up with the right pathophysiology so that we can tackle and mitigate the disease more effectively instead of shooting in the dark.
Well, actually, I forgot to mention, speaking of red light therapy, because I obviously had signed up, for the ambassador program, and I've got some of the equipment. I actually took the red light, since I'm not using it with the PRP lysate yet, and I've been shining it on the back of my neck, actually. So it kind of fits what we were talking about here. The fact that the red light, the way it's absorbed by the mitochondria, and I didn't, in the language of redox medicine, I've noticed it's taken a lot of practice, I would say, simply because, when you said the oxygen radicals get oxidized, and therefore it decreases oxidative stress, it's starting to make a lot more sense. I can see what red light is doing, besides just that. I think, before, my understanding is that it's like, oh yeah, we absorb it like the sun absorbs ultraviolet light. And then, of course, understanding that it sort of speeds up or enhances mitochondrial or the mitochondrial electron transport chain, but then getting it down to the even deeper science and understanding that you've got all of these oxygen-free radicals that need to be oxidized in order to get neutralized, and therefore what it's really doing is decreasing oxidative stress.
Mm-hmm.
In
right.
general,
so let me add something here.
It runs in both directions.
Right. Let me add something here very quick. Redox medicine and redox biology. There is a big organization in Utah. It's called Redox Biology and Medicine Society. The problem with those group, they're very scientific. They have very good publications. Their group, there's a big team there. You can say they are the original. But the problem is that they're a group of PhD and they don't translate their work into clinical. That's the reason me and Dr. Mike Beamer, we opened up a new Academy of Oxidative Stress-Related Diseases. And now it become Academy of Oxidative Disorder. It's a nonprofit organization. We have the board is being organized and everything, and hopefully Dr. James, you will be joining them as a board advisor, because you're most qualified to do that, because you are the one who's now adapting those protocols and hands-on So that's what we're looking for. We're looking for people who are clinically oriented and able to translate all the science into clinical. But there is already an organization, Dr. Mike Beamer, he's the COO for it, and I'm the founder, but there's other members who are now working on it, Dr. Albert Ray. This organization is going to provide a CME, and we would like you all to join that. The other organization that I am proceeding with is helping doctors in their clinic, which is the Chronic Disease Prevention and Management Centers, because that's a trend of medicine. In fact, that 60% of the adult populations, they are suffering from chronic disease. 60% of the adult population in the United States suffering from chronic disease. That's a big number. That's why Johns Hopkins and many universities, they open up departments for chronic disease management. And they have hospitals and centers for chronic disease management centers. It's a trend of medicine, and there are doctors now specialized to manage chronic disease, including all those metabolic, chronic inflammatory disease and all that. But they're doing it with the mainstream medicine. We're doing it better. We are adding integrated regenerative medicine as a combination along with mainstream medicine, and we are trying to get a doctor in each state to represent this center, to represent us. And that's where we can have a network all over the United States, plus other countries. I have doctors from Australia, they are reaching out to me, doctors from India, doctor from Austria, so doctor from Malaysia, they're all interested. So we're going to develop the centers of chronic disease management centers, especially with the head of COVID-19, because COVID-19 is going to add 14% to the 60% of the chronic disease in adult population. Why? Because COVID-19 did trigger all the epigenetics and of all these chronic diseases, so it happened more earlier. So if you have Alzheimer's, supposed to be by your genetic errors, happen at the start at the age of 70, but if you're infected with COVID-19, it's possible it will start at the age of 50. And so this kind of shifting of and triggering chronic disease early in the ages, it will add more to the percentage of the adult population suffering from COVID-19. And so we're going to have a specialty with chronic disease management specialists. There is already some clinics in the United States. They are presenting themselves as chronic disease management specialists. Okay, so you have to know that we're not bringing something out of the blue. It's already there, but it's not yet recognized in the mainstream. I think with our effort and our networking and the work that I'm doing with LinkedIn, I am sending message almost 10,000 messages each week to the LinkedIn that I have contacts. But it's a process, and hopefully we'll get there. But with your effort here, we have how many people here? We have almost 11 people here. So with your help, by joining the Chronic Disease Prevention Management Centers, a fellowship program, and if you are qualified to become a pioneer representing that state or country, then we can help to advance medicine and speed the whole process. If you don't have an active clinic, you can still join us as a fellowship, and we can provide you with all the training and protocols and equipments, plus weekly webinars that we're doing here to brainstorm and perfect the protocols. And also, if you have any hard to treat cases, we can discuss it here, and so you can get the best protocol to manage those hard to treat cases. We used to have Dr. Tom Urim every day bringing hard to treat cases. But I would like you in this group, if you have any questions, this is the day of Dr. Mike Beamer. Please raise your hands and ask a question. And sorry for interrupting Dr. Joseph and Mike Beamer. Go ahead.
No, not at all. I appreciate y'all listening. If there, anything I can help with, or we can probably collectively answer.
Yeah, no, actually, it was good to go over this case and go over it again because I think it's starting to make sense. I think there's a pattern to this thing, and it's not as much a mystery as it seemed to be. And also understanding what's going on in the redux language of what's going on that really is what it is. I think this is easier for me to understand because I understand redox reactions. Like I think I kind of understand. I didn't understand it. I didn't understand it the way I understand it now. That's the
Right.
main thing. I knew the verbiage, but I couldn't really see it in front of me. I don't know if you know what I mean, but the fact that we're able to make sense of, well, why would red light therapy work, or why would red attract blue, and what's this photosensitizing thing happening? Is the light causing the blue to release its oxygen reactive species onto the virus? Well, it makes sense when you understand that, well, viruses absorb the methylene blue. We don't. That's why we didn't use it in labs, because we could tell the difference between our cells and non-human cells. And the fact that methylene blue has always had a role in getting rid of viruses, any virus, regardless of what type of virus it is, whether it's West Nile virus. I saw that it was used and largely responsible for eradicating it, or making it not a pandemic anymore, and realizing that COVID's no different, and that I kind of liken it to a couple of things. Like if you imagine dynamite, but you push the lever down, there's a connection between dynamite, like almost like a rope, and the device that you push down on that actually blows up the dynamite. Well, it's kind of the same thing. I feel like it's happening inside of the mouth, is that the methylene blue stains the virus. It's almost like it's tagged. It's like, we got you. And then we hit it with the light, and that methylene blue, when it releases its reactive species, it damages the RNA of the virus, inactivating it or damaging it enough so that it's not able to, in general, you're not able to produce a full-fledged infectious sequel. The whole thing. Yeah, the whole infection is dampened completely, but your body is able to mount an antibody response. Like the study showed in Germany, 96% of the treated group developed antibodies. Well, it's reducing the viral load. You're able to kill most of the virus, or damage it enough so it's not as virulent, but we're able to reduce the viral load through photomodulation, such that the probability of you having serious disease goes down. But having mild disease and having it not be such a big deal is highly probable, especially if you're consistent in doing it. Like, don't forget, do it every day. I missed a couple days, and I had a high amount of exposure. However, like I said, the two people closest to me developed moderate infection, after I treated them. And I didn't even know I was sick. I have a stiff neck. Doesn't make sense. And I still kind of have little bouts of stiffness, but that's it. And I'm going to look to see that I actually mounted an antibody response. I'm convinced that it's very unlikely, in my opinion, that I would coincidentally, the three of us would have muscle spasms like that. And that's where I have to try to mix common sense, but also I'm still searching for literature to support that, additional support to support it, to at least validate.
Very interesting. When you talk about the COVID virus and the PDT, what's happening is that the RNA and the virus and some of the proteins has a negative charge, and methylene blue is a positive charge, and it's attracted to it, and it just rests there. and then but then when you activate it with the light, it is there for that when it hits that singlet phase, or at that very highest level of excitation, and it can create cross links between the RNA strands, and it's like a covalent bond, and it renders that strand of RNA inoperable. And then there's also something to do with the protein coat. It's kind of some denaturing process. But there were two mechanisms to that that I found.
Yeah, and let me go and emphasize on that. Influenza viruses, one of the methods to create vaccine is they take the influenza virus, and there's publication to support that. They take the influenza virus, they culture it, and they inactivate it. But there's many methods of inactivation. They can use formalin, they can use gamma radiation. So there's many ways, and one of the really more effective and more healthy way, instead of using all those toxins to inactivate, is using Methylene Blue photodynamic therapy. That's what they use. So creation of vaccine by the big pharma, they use Methylene Blue photodynamic therapy to inactivate the virus in vitro. And you create that weak virus, and then they inject it to the virus to prime the immune system. So this is the same thing that we're doing in oral Methylene Blue photodynamic therapy of COVID-19. We know the virus cultivate in the salivary glands of the mouth, and when we give the Methylene Blue and we do mouthwash, the Methylene Blue has the tendency to stain any inflamed tissue, whether it's cancer, infection. It's just any inflamed tissue, you will see it's dark blue. Normal tissue, because they have strong antioxidant capacity, they neutralize the Methylene Blue, and they turn it into leukomethylene blue, and they lose their color. And so you will see all the inflamed tissue and the salivary glands that's been inflamed, you will see it stained with Methylene Blue. That's why they use Methylene Blue staining process as a diagnosis for cancer, infection, and lesions in the mouth. It's already being done by the mainstream medicine. And so now when you head with light, and the Methylene Blue will be excited, the electrons will pick up by the oxygen, actually enhancing the reaction of Methylene Blue with oxygen, and you generate those free radicals. And those free radicals definitely will lead to oxidation, damage to the virus, and induce apoptosis and kill the whole cell that's being infected with virus. And activate the virus, so those viruses have become weak. Same thing that we're doing when we activate the viruses in the culture. Possibly those infected inactive viruses that's being shed from the mouth can provide some sort of herd immunity by, those weak viruses will start spreading instead of spreading the white viruses. We don't have evidence for that, but we have evidence that it inactivates the virus according to the PCR that's been done in Germany, and we show before and after. It's a quantitative, so you see the number of the virus decreased after the Methylene Blue photodynamic therapy. So we have evidence for that. The idea of this, turning those into an active virus, and then the patient will start spreading it to those inactive viruses and become like sort of herd immunity, or sort of providing immunization for other people. We don't have yet evidence for that, but the concept is there. We need to have some testing for that. Maybe we can do it on rats and see if we can have infected rat with COVID-19 and then do Methylene Blue and see if other rats, they get infected but without symptoms. And if that's the case, yes, then this rat is spreading an active virus, it's spreading vaccine. So you're producing in vivo vaccine. That's what I'm talking about. But we need to come up with that experiment. It would be good if somebody will adapt that, especially if somebody has a university here in this connections. That would be nice. Now, the other topic that I want to add is nano medicine. I just want to a little bit add something about it here, so you can understand why we are using platelet lysate versus PRP. And think about it. If you inject the PRP in the joints, okay, what would happen to those PRP? Of course, those PRP contain nanovesicles, and the nanovesicles contain the growth factors. So the PRP is a bag of little bags of exosomes that contain growth factors and RNAs, of course, and those growth factors and antioxidant enzymes and anti-inflammatory cytokines. Those are the drugs that we need to deliver to the joint tissue, right? But if you inject it in the form of platelets, okay, what will happen here? Who's going to pick up those platelets? Well, you have either synovial cells and the chondrocytes, and also you have macrophages and white blood cells there, right? Because those joints, most of the time, they're inflamed already. So who's going to engulf the platelets? Who's going to benefit from those exosomes that contain inside the platelets? I think most of those platelets will be engulfed by the macrophages. And so you're not getting much of exosomes or those nanovesicles inside the platelets getting into synovial cells or getting into the chondrocytes. It's the same if you have kids and you have a 6-year-old kid and then you have 6-month kid, right? And you put in front of them an apple. Who is able to eat this apple? The 6-year-old, because the 6-month doesn't have teeth and they cannot really grab the apple because it's too big for them. Okay, so how I can feed that little 6-month kid is smash that apple, and that way I can feed that 6-month kids. And of course you can, I mean, the 6-year-old can eat the smashed apple as well. So that's the reason I think platelet lysates will, the efficacy, it's better than PRP when you inject it into the joints. Because now you are injecting it in a nano size where it can be eaten by the synovial cells and the chondrocytes instead of being engulfed by the white blood cells in the joints. And that's the reason we're going to move all the PRP injections into platelet light, which is breaking them up and releasing their nanovesicles. The other thing is that even bone marrow stem cells and fat stem cells, when they inject into the blood, it's better if you break them down and release exosomes, and the exosomes will be targeted into the pathology, because the pathology is leakage, or it's leaky to the exosome, not to those big cells, not to the platelets, not to the bone marrow stem cells, and not to the fat stem cells. So breaking it down, I think it's better. Releasing there in the form of exosomes, you can get more delivery into the pathology. And if we know that the platelets contain almost similar growth factor that the bone marrow stem cells and the fat stem cells does, and you have also peripheral blood stem cells as well, and you can do it more frequent and you can do higher dose. So I think the movement to platelet lysates is the way that we want to do as a clinician. And I think we can get better results and compliance with the regulation by using your autologous platelets. The question is that some will say, well, you already have the platelet inside. Why does platelets will not release its growth factors, nanovesicles into the pathology? They will not. So you have circulating platelets. They will not release its nanovesicle growth factors, antioxidant, anti-inflammatory cytokines into pathology because they are inside a pack of platelets. That will not pass through the fenestration of the leaky blood vessels of the pathology. That's the reason you take it out, you break them out, you break them down by sonication, and then you inject it to the body as a form of nanovesicle. And yes, the nanovesicle have a tendency to seep through the leaky blood vessels of the pathology and get there. And so we're going to use that. It's equivalent to the exosomes. And also we're going to use the sonication method in loading drugs. So you can load vitamin C, you can load your Myers cocktail, vitamin D, you can also load steroids, cancer drug, photosensitizer, whatever you want to inject in the body, you can sonicate it. We have the protocol for that. We have a whole system for that. You can sonicate it with platelets. You break the platelets down, you load those in nanovesicle, and there's already publication to support that. And I will share it with you, and you can get those medication into the target. So I would like you all to start changing your clinics from regenerative integrative into chronic disease management center or become a chronic disease management specialist. Again, there's already doctors are doing it. So if you Google chronic disease management specialist, you will see doctors are moving to that direction. And in that way, you can increase the spectrum of your treatment. Now you can treat cancer, infection, you can treat degenerative disease and all medical specialties. And I think that's what we need, especially with post-COVID-19 reality. I think the medicine is changing. It's more virtual, and there is a big demands of doctors and needs, and they can help those patients with chronic disease, especially because we know the COVID-19 is triggering more chronic diseases. And we know those people with chronic diseases, they have high risk of descending into cytokine storm. So there's a big demand there. And if you join this movement and you join the fellowship program that we have, and of course, you need the CME, and the CME, you can get it from the Academy of Oxidative Disorder, which is operated by Dr. Mike Beamer, or Academy of Stem Cell Physician, which is being run by Dr. Fashan and Dr. Dayton. Both of them are nonprofit. Hopefully, they will delegate, hopefully, and they work together as one. That's something we're going to work together, me and Dr. Fashan, I think he's here. And very importantly, that Dr. Fashan does have his Academy of Stem Cell Physician on November 8 and 7 or 8 and 9. But I will give him this opportunity to go ahead and promote your academy. Dr. Fashan, are you there?
Yes, sir. Thank you so much. The meeting is on this Saturday and Sunday. Starts at 10:30 in the morning, and it's going to be run just like a regular meeting that we had in the past. We even going to have a workshop. Dr. William Hung is going to demonstrate lipoaspiration. We're going to have exhibitors. People are going to talk for 50 minutes, and then the exhibitor is going to talk for 5 minutes, and then on and on. We have the FDA director coming to give us the latest in the regulations, as well as we have Dr. John Laddo, who is expert in the field of exosomes. He's a PhD, and all he does is exosomes. He's going to talk about. So we have some new speakers, and we have some of the speakers that has spoken in the past, but they have new stuff. We're going to have the oral examination, and as well as the written exam. So we're gonna basically do it like the way, because that's how it's gonna be, Dr. Halasa. I think that those meetings that we used to have, I mean, I spoke to the exhibitor, and he says, no thanks, I'm gonna wait for the day that virus is gonna be gone, so we can be shaking hands with the people. And I think that even if that day comes, most of us, the physicians who've been benefiting from the Zoom, we may not go. We may just decide to continue learning it from Zoom. The expenses are less. When we were doing this in the hotels, sometimes our hotel bill was as high as $180,000. And it was very difficult to raise that money because of selling tickets. But here with the Zoom, it's going to be for free for all the physicians. Anybody who wants to showcase their product, they get to speak for 5 minutes, and they can show their logo. So again, it's a good opportunity for doctors and exhibitors to match up again. I think that is one of the important things about the meeting that we didn't have last time. We didn't have exhibitors because we wanted to do just talks. And I think that would kind of like, it'd be more fun to have that. Let's hope so. So again, you're all invited for free. Please come. You register at the website, and the Zoom address is the same as what it was. And if you have any friends or anybody who's interested in the field of stem cells or nitro medicine, Dr. Halasa is going to be talking, Dr. Irma is going to be talking. So there's going to be talk on peptides, on a variety of subjects. Again, this would be really fun and good. I'm really looking forward to it because, you know, just very quickly, we're doing these meetings like 10, 12 times a year, and it was like traveling was really good. Was, you know, meeting new people like you guys, and now we have to do it through Zoom, and hopefully it goes back to what it was. But I have a feeling that this is going to, just like you mentioned earlier, it's going to stay for a while, and that's the way of life. Again, thank you for giving me some time, Dr. Halasa, to talk about the upcoming meeting on Saturday and Sunday. Thank you again.
Yeah, so I need you to connect with Dr. Mike Beamer, please, because he's going to present what he just presented tomorrow with 300 doctors. And also I want him to join you, exhibit in your conference, sponsor you, and possibly we're going to have some joint venture together where we can combine those two nonprofit academies. So this is something, if you're interested, Mike Beamer is going to delegate that with you specifically.
Very much interested. You know.
Yeah, hi, Dr. J. Yeah, I spoke to your assistant or someone today. Yeah, so we'll speak again. Absolutely, yeah, we're big supporters.
There's like only a couple of spots available. If the schedule is up, take a look at it. We're expecting a huge crowd because
yeah, he said 160 or more. Yeah.
Yeah, we spent a lot of money advertising this event. You know, we did it on LinkedIn. I'm talking to you at least $10,000. LinkedIn, we advertise on Facebook. We've been telling our own members, our own mailing list, you name it. So hopefully it'd be, you know, the more the better, of course. But we also have great subjects. Who are covering great subjects. There is an exhibitor who's going to be talking about some of these procedures being covered by insurances. There's an exhibitor who's talking about some of the products they're selling. There's a couple of pharmacies. So if your product, which is basically Methylene Blue, people need to hear about that, you know, and that's something you want to do that, just let me know, or tomorrow.
Absolutely.
Yeah, make room for you.
Thank you, Dr.
I appreciate that. I appreciate you again, Dr. Halasa, and thank you for giving us a chance to speak about this. Thank you.
Yeah,
anytime.
Well,
thank you.
Well worth it. Well worth it.
So any questions for Dr. Mike Beamer? Everything is good. Dr. Salahuddin Sharif, you're from Libya, right? Dr. Salah, are you there? Where are you from originally?
I'm from Kuwait, man. I live in Kuwait right now.
Where? Iraq?
No, I'm Colorado. I'm living in Colorado, AST.
Oh, Colorado. Yes. But originally from Libya, right?
Okay. Yes.
So what do you do right now?
Yes. I'm doing PhD in exercise physiology. I'm working on chemotherapy called doxorubicin and how it can prevent side effect and toxicity by exercise and supplementation. Yeah.
Oh, that's cool. That's cool.
Very interesting.
And I mean, and they have a not so good experience in about redoxa and oxidative process, but it's very interesting. I mean, it's not killing the cancer cell, but also have effect on other healthy cells like cardiac muscle, like skeletal muscle. That's what chemotherapy is causes the cardiotoxicity, which might lead to congestive heart failure, or mitotoxicity like muscle cachexia, atrophy, and all of this have a very, very negative impact on cancer population. And one of the mechanisms of chemotherapy is during redox, increasing oxidative process. We found exercise can help those people by increasing antioxidase enzyme.
Right. And that's what we're talking about.
Yeah, I mean, but I'm using more, my specific more with exercise as
Right.
lifestyle with the diet and nutrition, like creatine supplementation. I think for me, this is more help. And good thing, I mean, I have a good background in clinic. I'm a physician, but I'm not licensed in the United States to work as a physician. But
Right,
my
but
goal
that's what
future-
we're doing here. Exercising is one of the nitroredox modulator, does express antioxidant capacity, gene expression that we call redox sensitive epigenetics, increasing the antioxidants, enzymes, and yes, that helps to mitigate the side effects of the fat-free radicals, texture-free radicals that's coming up from the chemotherapy, especially the naked chemotherapy, where it affects all the tissues, healthy and the cancer. The nano chemotherapy does have less effect on the healthy tissues. So that's why we are moving to nano medicine. But nutrition, yes, that's right. Methylene Blue is very effective as well to buffer the redox for the healthy tissue, and many more. You know, it's curcumin and all this stuff. And Dr. Benjamin, also from Libya, he came here and he present the same thing. He specialized. He's a cardiologist, and he specialized on mitigating the side effects of chemotherapy on the cardiovascular diseases. So the same thing that you're doing with exercise, same thing. You know Dr. Benjamin, right?
No, I never, no.
Yeah, I think he's from Musrata or somewhere. But he was here. He presented in one of the conference series.
No, there's now the new field is called cardio-oncology. It's getting popular right now in the United States about how to prevent like toxicity from chemotherapy and cancer.
Right, that's the same specialty of Dr. Benjamin.
Yes, yeah.
Yeah, Benjamin. Yeah. So this is a very good field. This was what we're doing.
And they help so, yes.
Yeah, but we're doing it with many methods. You know, you can use also light photomedicine. You can use nutraceutical, big pharma, exercise. There's many approach to enhance the antioxidant capacity, minimize the side effects of chemotherapy.
We would love to hear about your work. That would be very interesting to invite you to present your work as related to some subject about.
You talk to me, sir.
Yeah, they want you to be a speaker.
From
Can you go ahead and come present what you present and what you're publishing?
Yeah, sure. I love to. Yeah, I love to. Yeah.
Okay, great, beautiful.
I can present this, even like part of my dissertation. I'm finishing. I'm still working on my dissertation. Yeah.
Mm-hmm. Well, we have interest in hearing the scientists just as much as the clinicians, so we can synthesize the ideas, right?
All right.
Yeah. I love to.
That would be wonderful. Well, please contact us. Yeah. Send Dr. Halasa your email, and we will communicate with you. We'd love to know more about your work.
Yeah.
Absolutely.
Sure, I love to. Yeah.
You want to go ahead and conclude the event, Dr. Mike Beamer?
Yeah, well, thank you everybody for coming. It's been nice to have everyone, and especially thank you to each of you. I know each of you, and I appreciate everything listening. And let's meet again next week if we can. And best of luck and much love to all of you.
Yeah, we published this on YouTube, so we're gonna get it on the video. It's a very beautiful presentation. Thank you very much, Dr. Mike. Okay, thank you everybody. Thank you. Good night.
Thank you.
Dr. Salah. Thank you.
Thank you. Bye.